You're listening to the Assembly on Pulmonary Circulation podcast, brought to you by the American Thoracic Society.
Welcome back, everyone, to Practical PH, where we invite experts in the field to talk about a wide range of topics within pulmonary hypertension, with a particular focus on providing practical pearls. My name is Catherine Del Valle, a PH specialist at Mayo Clinic in Rochester.
And I'm Khushbu Goyal, a PH specialist at Cedars-Sinai in LA. So we know it's been a while since our last episode previewing all the pulmonary circulation sessions at ATS, but we're back today with a new series called Foundations of PH. We're lucky to be joined by Dr. Namita Sood, professor of medicine at the University of California, Davis. She's the co-director of the Pulmonary Hypertension Program and the director of the Advanced Lung Disease Program at UC Davis. And today we'll be talking about how to evaluate and diagnose pulmonary hypertension, and how to connect patients to expert PH centers.
So, Dr. Sood, we like to start Practical PH by asking our guests about their journey into the world of PH. So, how did you become interested in pulmonary vascular disease, and what excites you the most about the field?
So for me, it wasn't like an active choice. It just happened. I was a first-year fellow at the University of North Carolina. My focus was microbial epithelial interactions and ventilator-associated pneumonia, and kind of planning to be an ICU doc when I diagnosed a 60-some-year-old lady with idiopathic pulmonary arterial hypertension. I was like, of course, it was a fellows clinic, but I was like the third or fourth pulmonologist she was seeing. And at that time, I sort of suggested to her we send her to one of the centers, Dr. Lou Rubin, actually in Maryland, and she said she'd seen too many doctors and she'd rather stay here. So that was my first pulmonary arterial hypertension patient that I treated with treprostinil. And from there, by the end of my first year, I had 5 patients, and by the end of my fellowship, we'd established a PH clinic at UNC. So then I kind of got hired to the Ohio State University to set up their pulmonary vascular disease. So that's what I focused on for the next 17 years of my life. So that's how it all started and developed. Yeah.
That's awesome. Thank you for sharing. So we'll get into today's episode and topic by starting off with a patient case, as we always do. So Dr. Sood, you're seeing a new patient in your clinic who's been referred to you for PH. She's a 45-year-old lady with hypothyroidism and a history of unprovoked DVT on a DOAC, with a chief complaint of progressive shortness of breath, leg swelling, and a chronic dry cough. When you look at her outside records, you see that the reason for referral is an echocardiogram, which reports a PA systolic pressure of 50 and says, quote, severe pulmonary hypertension in the interpretation. But before we get too ahead of ourselves, we know that the journey to any diagnosis always starts with a good HPI. So what questions do you ask patients who are referred to you for possible pulmonary hypertension?
Yeah. So I'm going to start by saying that, even after years of doing this, the hardest thing in pulmonary arterial hypertension is to appropriately phenotype the patient. That really is, it's all about the workup, right? It's all about getting a good history and the workup. So I take a few shortcuts because I give my patients a detailed questionnaire. Even like before they see me in clinic, everybody gets this questionnaire that they have to fill out, which kind of is spread kind of structured initially starting with their symptoms, which then when I'm sort of translating that to my note or sort of assessing the patient, it gives me an idea as to what their functional class or their risk stratification is going to be should they have PH, then followed by their past medical history with sort of specific questions regarding any autoimmune disease and so forth, their exposure history, tobacco, previous chemotherapy, drugs, recreational drug use. So it just kind of goes into this whole thing because I think pulmonary hypertension is not a disease that is sort of in isolation, right? It is a manifestation of a disease in the lung that could be related to many systemic diseases. So knowing if they have systemic hypertension, have they had cancer before, do they have renal disease? All that is so important to us. So I kind of take that shortcut and I just get that captured proactively from the patient. So when I'm doing my note, all that information is in front of me in case my visit was hurried or I forgot to ask the question. It is there for me to review when I'm actually putting it in my notes. So I think a good detailed history. I feel like rheumatologists, nephrologists always take better histories than us, and I think we just need to be in that club and get a very detailed history starting out. And so I think specifically asking about exposures, drug use, or other associated illnesses, especially hypertension, sleep apnea, renal disease, yeah, blood issues, previous chemotherapy, autoimmune disease. I think that's all very important. So I think we just need to get a very detailed history, like a good internist in every patient.
Absolutely. I think that's so important. And I'm so glad you underscored the importance of the history because I think a lot of times our patients will tell us where we should go if we listen carefully.
Mhm.
To give you some more information about this particular patient, she says that her shortness of breath has gradually worsened over the past few years, coupled with some issues with bilateral leg swelling, for which she's needed some Lasix. She also notices that her hands and fingers are very sensitive to cold weather and tend to turn red or white, and that she has some difficulty swallowing solid food. She has a 15-pack year smoking history and quit about 10 years ago. She denies any recreational drug use. On exam, she has some fine inspiratory crackles at the lung base, some trace pitting edema along her shins, and some tightening of her skin when she tries to make a fist. Based on her history and physical exam, what do you think her biggest risk factors for PH are, and what other workup should we do?
So I think you're presenting to me a case with symptoms of scleroderma, and it could be any other sort of overlap autoimmune disease with that. So the workup, again, it doesn't matter where the patient starts, right? So this one sort of seems like a very easy patient that, the patient has scleroderma. Now she had an increased RVSP. And of course, she's at high risk of developing pulmonary hypertension. So bingo, we have the diagnosis. But unfortunately, even in the patients where things seem this obvious, it is not that easy, right? So there are no shortcuts to a proper workup, right? Everybody needs the complete workup. It doesn't matter how simple things appear. So the echo, which is our usual screening test to consider if the patient might have pulmonary hypertension, is not a diagnostic test. It is a screening test. And we want to use that echo to look at several things here. Number one, I tell my fellows and all, I'm like, you look at the left side first. What is the EF on that, reported on that? What is the left atrium looking like? Is the mitral valve healthy, right? And then you look at the right-sided chambers. Is the right atrium enlarged? Is the right ventricle enlarged? Is the septum? Is there a pericardial effusion? And then train your eyes to that TR jet velocity that everybody gets focused on, right? And then you have basically looked at the echo. You want to exclude left heart disease. You want to see if you want to worry about pulmonary hypertension. And even if the RVSP is not that increased, but if my right-sided chambers are enlarged, I am worried. Or if my septum is bowing into the LV during systole, I am very, very worried, right? So you got to look at the whole echo, and we use it to say, am I worried about pulmonary hypertension? But also we use it to say, what is the state of my left heart? Because that is the commonest reason for elevated PA pressures. So starting with the echo, then I hope in our history we got symptoms of that might suggest airway or parenchymal lung disease, right? Does the patient have a chronic cough? Are they, coughing up sputum? Have they had a history of tobacco use? But after that, you need full set of pulmonary function tests on this patient, a physical exam. If there is any risk factors, any suggestion that the patient might have parenchymal lung disease, or any risk factors that they might have parenchymal lung disease, these patients need a high resolution CT scan to look at the parenchyma, right? Thromboembolic disease is never going to announce itself till we look for it. So everybody gets a ventilation perfusion scan. And then our routine labs, we want to look at our LFTs, we want to look for HIV, it's a treatable disease. So no matter how you cut it, how many years you do it, that workup has to be complete. And the way we do this, again, many years ago, I told you I started as a fellow, so I was very afraid. So we created this little sheet where we would complete the whole thing, the patient's information, their exposure, and then their echocardiogram, their VQ scan, and then fill it up before the patient underwent a right heart cath. And that bits of that have now been embedded into my Epic note. So when we get patients from outside, we incorporate the data we have, the missing data we order before we kind of arrive at a diagnosis and treatment for the patient. And you just have to set up some process because otherwise, no matter how good you are and how long you've been doing it, it is hard to keep track of if the workup has been complete or no. And the problem is that if you phenotype the patient incorrectly, that patient is not going to get better. Right. So it's
Yeah.
a lot of wasted effort and time and expense at every end. Yeah.
Yeah, I think you make two really good points about how systematic we have to be with pH, which is that don't make any assumptions and really go through each of those WHO group classifications and all the subclassifications and really we have to evaluate for everything. And then the second important point was that the echocardiogram is not a formal diagnosis, but it really does help you risk stratify how worried you are about pH. So Catherine, I guess you want to give us some more information on this case?
I absolutely. I think we got most of the information that Dr. Sood recommended. So this patient has an estimated pulmonary arterial systolic pressure on echo of 50. The echo also shows a moderately dilated right ventricle with mildly reduced function and RV pressure and overload suggested. She has a normal left ventricular ejection fraction. So overall, this is pretty concerning for pulmonary hypertension, especially when coupled with her history and physical exam. So you proceed with all of the workup we've talked about, and that reveals a positive ANA screen, a positive SCL70 antibody, a pulmonary function testing that demonstrates moderate restrictive defect and a reduced diffusion capacity. And she has a high resolution CT chest, which shows a UIP pattern with basilar predominant reticulations, honeycombing, and traction bronchiectasis. You also go ahead and prescribe scheduled Lasix, which she's used intermittently in the past. So you do all of those things and fast forwarding to a follow-up appointment. At that point, she's symptomatically about the same, but the edema has resolved a bit with the Lasix. So at this point, Dr. Sood, what do you counsel this patient about, and what are your next steps to diagnose her?
So I think this is looking like a patient who has scleroderma based on the autoimmune profile and the physical findings you suggested with interstitial lung disease, and she may or may not have pulmonary hypertension associated with that. So I think several things need to happen at this time. Number one, I want to be sure that she's established with the rheumatologist and we're addressing the interstitial lung disease. And I want to be sure that we have assessed her for needs for supplemental oxygen, with her walk test and so forth, and optimize that. I want to be sure that she doesn't have any symptoms or to suggest that she might have sleep apnea. If she has, then I would address that as well. And then she needs a right heart catheterization to assess her hemodynamics to arrive at a diagnosis of pulmonary hypertension if she has it or no. And is it pre-capillary or pre and post-capillary and so forth.
And how does your pretest probability for what type of pulmonary hypertension or clinical classification affect how that right heart cath is done? I think sometimes we forget that it's not just getting resting right heart cath numbers. We might do other maneuvers, whether it's vasoreactivity testing or a fluid challenge or a shunt run. So do you mind just commenting a little bit about that and what some of those tests are and in which scenarios are those actually relevant? So maybe in this case, maybe not in this case.
Yeah. So the vasodilator challenge, which is the commonest one we use. So the question the test asks is my patient going to be a candidate for calcium channel blockers, right? So if you have a patient that you think has idiopathic pulmonary arterial hypertension based on your initial workup, the patient still has good RV function, and in that case, then a vasodilator challenge with inhaled nitric oxide is indicated to see if the PA pressures drop down and without dropping the cardiac output. In that case, that patient could benefit from calcium channel blockers, right? So that's the vasodilator challenge. It's only been validated and studied in patients with idiopathic pulmonary arterial hypertension, not in any other type of PH. Now, the other one that is frequently being used, because remember, the commonest cause for pulmonary hypertension is left heart disease. And where we get very, very confused as PH physicians is when we have elevated PA pressures, but the left side of the heart doesn't look normal, and the wedge is right at that cusp. So the normal LVEDP is actually less than 10 in most people, right? Your wedge is supposed to be 10 or less, but then we give it 2 standard deviations away and we say 15 is good. So when it's sitting right at that 15 or 14, my LV on the echocardiogram looks a little bit stiffer. The patient has a long-standing history of systemic hypertension. The left atrium looks mildly dilated. And my PA pressures, my mean PA pressure is 35 or 40. So then I'm confused. Is this patient pulmonary arterial hypertension, or is it my brain is screaming that there has to be an element of left heart disease, but I'm thinking the numbers are looking like precapillary. So in that case, you could challenge the left heart a little bit, right? And the way you can do it is by doing a leg raise. Basically, when you do a leg raise, you immediately increase the return to the venous system, and with that, if the wedge goes up, that suggests that the left side may not be that healthy, right? Or you could do a fluid challenge where you give 500 cc's of fluid and see what happens to your wedge pressure. The third setting could be doing exercise testing, where you exercise the patient. Normally, the PA pressure should go up. The cardiac output should, in a healthy patient, the PA pressure should go up, the cardiac output should go up, and your PVR should actually come down. In patients with PAH, the PA pressures would go up, the cardiac output would drop, and your PVR would go up, but your wedge would stay about the same. But somebody with left heart disease, the PA pressures might go up and the wedge kind of goes up at the same time, and the cardiac output could drop if you continue with the exercise. So that way you're sort of trying to separate out where the pathology is at and what is the pressures being, what is driving the pressures. The challenge with these challenges is that the vasodilator challenge in PAH is the easiest one. Everything else is a little bit nuanced. So you really need to sort of be mindful of getting all the numbers together, looking at the waveforms very, very carefully, and sort of picking up the right patients. How the pulmonary vascular bed responds in patient who has interstitial lung disease with these challenges has not been studied. So we really don't know when, especially, patient with scleroderma, older patient, you would be worried that maybe there is left heart involvement. But if they have interstitial lung disease, how to use and interpret these challenges has not been well studied. So I would discourage people from doing them at this time.
Absolutely.
Doesn't
So
it?
it really seems like we have to not only obtain a history with intention, an exam with
Yeah,
intention, but also Cath with intention to
yeah,
make sure we're putting things together
yeah.
correctly. So for our
The
patients,
important, can I make one other point? The
yes,
important
please.
thing with the Cath is really to look at the waveforms very carefully, right? Because a lot of times they get interpreted just by the computer reading, like drawing the line, and then we do the challenge, and then we just follow whatever is being read. But if we pay attention to the waveforms and what is the variation that is happening with that challenge or the exercise or the breathing, then I think you'll get a little bit more information out of those tracings.
Absolutely. That is such an important point. So in our patient, she undergoes the right heart cath, and her numbers, after you've reviewed the waveforms and made sure everything is correct, her mean PA pressure is 32 with a wedge pressure of 8. Her thermodilution cardiac output is 4, which results in a thermodilution pulmonary vascular resistance of about 6 Wood units. So this is
Mm-hmm.
confirming the diagnosis of precapillary pulmonary
Mm-hmm.
hypertension.
Mm-hmm.
And then the next step will be to determine a treatment plan for her PH based on what we think her primary WHO group clinical classification is. We'll talk about the treatment approach kind of more in a future episode of Practical PH, but today we wanted to focus on this process of getting to the PH diagnosis.
So to conclude, so this patient has PH ILD in the setting of scleroderma, right? So here we started thinking that this would probably be a slam dunk, PH related to scleroderma, but when we kind of looked at the patient in a little bit more detail, she does have interstitial lung disease as well. So she kind of falls into that group 3 CTD-ILD with pH, right?
Absolutely.
Yeah.
Exactly. And so for our audience listening and all the clinicians out there, we wanted to highlight a couple take-home points for this particular case. So one is, as we've highlighted already, is how important it is to be systematic about evaluating for pH risk factors through a good history, physical, and other standard diagnostic studies. So no cutting of corners. And the second is to remember that the formal diagnosis of pH always relies on hemodynamic data via a right heart catheterization and coupled with a WHO group classification based on your workup. So we shouldn't be starting pulmonary vasodilator therapy based only on an echo, since as we found in this case, the treatment approach can be very different depending on the type of pH, which you can't assess only with an echo, as Dr. Sood so nicely outlined for us.
And another thing I wanted to bring up in this discussion was that, Dr. Sood, you have the perspective of being a pH specialist at a PHA accredited, Center of Comprehensive Care. So can you talk about when patients should be referred to expert pH centers and how physicians in the community can really find where to refer patients?
Yeah. So thank you. So I heard somebody did this. They asked ChatGPT, like, how to manage a PH patient, and one of the top things that came out it referred to a PH center, which would be great, right? But it's not always practical. The insurance companies don't sometimes, approve the closest center that is available for that patient. Sometimes travel expense is a problem, and sometimes patients just don't feel comfortable coming into cities and so forth. So we have to, I think we as the PH centers, we have to reach out and partner with make ourselves aware to the physicians in the community, and then be available to them as a resource at whatever level they need us to be. Sometimes people will do the workup and they send them to us for right heart cath. Sometimes they will do the full workup and they just want to run the patient by to get like what should I start the patient on treatment, or they will do the initial treatment, and if the patient's not improved, or they start the treatment and they just want to check in for us to see that if the patient is appropriately treated. So I think we have to make ourselves available to the physicians in whatever capacity they would like us to consult on. And I would say to the community physicians, like, it is hard, even at the best of centers, it is sometimes hard to get a comprehensive workup in a timely manner. And we are happy to help them with that. And they should have a lower threshold to send the patients over to us. And, the PHA has a very nice website where they list all the centers, the regional centers, the centers, comprehensive centers of care, where with their information as to how to reach them. And that is a resource for all the community physicians to use.
Well, Dr. Sood, thank you so, so much for sharing your expertise and time with us today. This has been a phenomenal session. I know I learned a lot, and I'm sure our audience did as well. So thank you so much.
Thank you.
And to our listeners, stay tuned for our next episode in this Foundations of pH series, which will be about risk stratification of pH with another very special guest.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.